To all of you. At the outset, I'd like to thank all of you for giving me an opportunity to start with a very basic topic on the aspects of the phaco. But what I like to mention that in this modern era, cataract surgery has become more a refractive surgery with a demand for better quality of life and a better quality of vision. But how to best satisfy this demand has become the utmost priority for most of the eye surgeons because it encompasses their understanding of the neuro-ocular anatomy, the physiology, the pathology, in order to able to achieve a desired refractive outcome after doing a cataract surgery. So what we believe that the outcome of phaco surgery definitely affects the quality of vision and life, where the one of the most important, especially for the residents, I feel that you should start learning to make a very well-centered CCC because it is this factor which governs the effective lens positioning. The others are definitely we want to have a much decreased phaco energy and its effect on the endothelial cells. So there are different aspects which really governs the position of the IOL, and this is capsulotomy plays a very important role where if it is too small, we usually get a hyperopic shift, and if it is too large, we get a myopic shift, and this effective lens position changes. If it moves back, what I have already mentioned, it leads to a little bit of hyperopia, and front it leads to myopia. So this is what I like to show, that this all the CCC, which if we can do a very nicely well-centered one, and if we can have a very nice capture, it really gives a very good effective lens positioning, and the chance of later having some amount of refractive changes is much less. So when we talk about A to Z of the phaco, the most important is the incision. What I always insist that one is what we want a very continuous curvilinear axis, and because this usually gives a very high strength to the capsule, especially when we do the surgical procedure with a very high fluctuation of IOP as well as a bombardment with the phaco probe and the nuclear fragmentation. Start with a tangential force and in a curvilinear movement, and there are different ways of doing it. Many surgeons prefer the forceps, but I usually like to use a cystitome. And once you do the capsular axis, most of the surgery, almost 50% of the surgery becomes much easier. Not necessary that it should be round always, but you should have a continuous one. And the next important step is the incision, which I prefer doing a clear corneal temporal, because I feel that I get a better red glow, and especially in the deep-seated eye, especially in Northeast, we get the eyes very deep-seated, and most important, there's less pooling of the fluid in the fornices with better red reflex and less chance of your locking of the instrument in the temporal approach. So once this is being done, the incision is done, this is being followed by hydrodissection, hydrodelineation, and then we have the lensectomy. This lens fragmentation can be done by different technology, which can be very classically, when we all started, it was basically a divide and conquer, then that is stop and chop, and also now what most of us prefer is the direct chopping. So once you take out the lens, you have the remaining epinucleus and the nuclear cortex that needs to be removed. So these are some of the steps, but every step is important. But what even today I feel the most important step to have very successful cataract surgery is definitely a good capsular axis. So once you do the cortex aspiration, you give the intraocular lens, and following the intraocular lens implantation, a very good washout of viscoelastics. Especially what I do, I usually wash it always behind the IOL in order to prevent the post-operative inflammation or any high intraocular pressure. So this is also another patient where I can show you rhexis is very important, especially when you talk about the basic of cataract surgery. Definitely the rhexis plays a very important role. So, and then this also helps you to consider thinking of the high premium IOLs. So this is also very fast, the different steps. I think I'll not be showing this video because of the paucity of time. So this is what we want. We need a rhexis which is very well centered, and this usually comes with practice, and as we keep on developing ourselves, we can find that it becomes reproducible in most of the cases, which may not be always possible in a manual situation. The challenges occurs when we have something like this, a very dense cataract. It is not that it is not possible to do, but what happens in a very dense cataract, sometimes we end up using too much of energy. There can be changes in the endothelium. The next day you may not have a very clear cornea, and many times we find that flex helps in such situation, where one of the most important indication of flex I feel is especially in denser cataract. And also the advantage, you have a very reproducible axis which is consistent in every of the cases, and also with less amount of the phaco energy you can go ahead with very good surgery. Like situation like this, a cataract nigra, which is really very dense, and if you really plan for doing a phaco surgery, I feel a initial lensectomy, if it can be done with the laser, the amount of the power energy is much less, because most of the studies have already shown that a high energy of the phaco might lead to some of the endothelial changes. And yes, I think everyone doing a flex procedure, they'll agree that white cataract, it is really a blessing for the white cataract, because now with the advantage of different settings, you can also have a very good capsular axis. Hardly we get any extension of the capsular axis now. And now, so we had done a very good study to find out the actual benefits of flex over the manual capsular axis. And what we had done, we were basically seeing some of the capsular axis factor and also some of the IOL factor, and we randomized the patient to receive either the flex or the manual phaco, and had done the post-operative slit lamp examination in all the cases. We have used this software of National Institute of Health, where we have tried to analyze the capsular axis parameter, which especially in terms of the circularity, where we have mentioned both the horizontal and the vertical in every case, and to see how reproducible and consistent is this, whether you use a flex procedure or whether you go for a manual capsular axis. And then once we have measured in both the horizontal and the vertical and has found the circular diameter, we had also taken some of the IOL related parameters, and the most important is basically measuring the centration of the IOL, and also secondly how much amount of overlap of the rhexis IOL is there. And then what we have found, that definitely we found that in terms of circularity it is lesser in case of manual capsule, and which is a known fact and thing. And also, but we found some amount of IOL decentration in this white cataract, which was done with a manual and as compared which was done with the flex. So I feel that yes, flex also helps in some situation like PPC, when you have something like this, and if you can already pre-cut with the laser by doing a different cylinders, it really makes your surgery a much safer one. And these are only like, even when you plan for a very premium IOL, in such technique, if you can, especially in the premium IOL, it really helps in such situation. So before I conclude, I like to mention that yes, the basics always starts with a manual phaco. You should know every step of phaco emulsification that you do. You should be very confident. Every step is important, whether it's an incision, whether it's a hydrodissection, whether it's a capsular axis. And with this, there are some technological advances. If you have this technique, yes, it adds a better outcome. And even what I was mentioning, there are reports now saying that with the flex, the chance of PCR in a PPC is much less as compared to the manual phacoemulsification. Thank you very much for your patient hearing.
Thank you, Dr. Kasturi.
Thank you for covering A to Z.
A to Z, yes. Audience, do you want to ask some questions?
Excellent phaco surgeons are sitting here.
Now next is Dr. Sudipta Mitra. The topic will be exploring new skylines after the unexpected surprise post-operative.
This one? Video? Only video.
This last day of the first Mid-Con conference of AIOC, respected chairpersons and my dear friends, I'm extremely happy to be here. And the topic on which I'm going to talk today is a little different. This is exploring newer skylines after unexpected surprises post-operative. Can I please have the audio? There's an audio in it, in a very low tone. Yeah. So this was, I have no financial interest in anything I'm going to talk today. This was a female which was 28 years old female who came to me with cataract in bilateral both eyes, -33 in right eye and -35 in left eye. She had high myopic glasses, history of high myopic glasses. And she had a myopic fundus, but somehow she did not have posterior stiff ulna. We excluded by ultrasound and other methods. There's not much of myopic degeneration. And on doing our biometry, found the emetropia was at -19 and -18, which is very, very unusual for us, and it was not possible to get some such type of a IOL. So we tailor-made these IOLs. Now these lenses, these eyes, we know that end up in hypermetropia. So first, our right eye, we targeted 2.5 myopia with -17.5 IOL, but she wanted freedom for glasses. So we targeted 4 diopter myopia in left eye, but this is what we ended up in. It was a huge surprise. Right eye plus 4 diopter hypermetropic, and left eye plus 1.75, 6.9 either eye, and we did not know what to do. So a myopic turning into hypermetropic is...
to hypermetropic is very, very difficult to adjust.
Please put it down. I'm talking because it was not there. So anyway, we thought of how to give her freedom from it for IOL exchange or a piggyback IOL, because we couldn't think of IOL exchange. So we did a pentacam and we found that the anterior chamber depth was sufficient. There was no other problem. The thickness of the cornea was okay, and counts were all right. We did a refractive correction, spherical equivalent digital measurements, and we found out she had nearly 4.5 spherical acceptance with 6.9 vision. So looking into all these parameters, we had to decide on either a piggyback or a sulcus fixated IOL. So we thought of putting a sulcus fixated IOL, and this was my first experience in it. This was during COVID times. We did not have access to any other IOLs of MNC companies which can be put in the sulcus. Ideally, it should have been a hydrophilic over silicon over a hydrophilic, or a hydrophilic over a silicon this type, but this was a hydrophilic over a hydrophilic. I had no other option because she had a lot of hypermetropia. Although she was happy, I was not happy. So this, most of us who are doing phakic IOLs would be acquainted with these type of lenses, and this was nothing different, just 4 haptics, thin haptics. We used 6.5 in the first eye, right eye, and this was the formula was 1.5 into the spherical equivalent. And just like a phakic IOL, you can see the posterior chamber IOL sitting in the bag beautifully, and we used 2 side ports horizontally opposite, and 2.8 millimeter keratoome to make the main wound. And just like a phakic IOL, we had already folded the lens. This was not a pre-filled one, and inflated the anterior chamber with sufficient amount of viscoelastic, not too much, not too less. And this was nearly at the limbus, in a clear cornea. And this injector is 2.8 millimeter injector. So the steps were more or less similar to that of a phakic IOL. I usually use with a phakic IOL a spatula in the left hand to guide my IOL, and this was also the same. The only difference was that I did not want to deliver it inside the iris, rather I delivered it over the iris, because I had to put it in the sulcus, not in the bag. And in case it went in the bag, I would be in a soup. So I just delivered the leading haptics on the iris, and then the trailing haptics too. And as you can see, that was the notch, the leading haptic which has a notch which has been marked, and this is the identification that has been placed properly. So, and there's a tucker which we use in phakic IOLs also. I use the same tucker, and with the help of the spatula, pushing the optic slightly in the opposite side, one by one I tucked it. Now it is little different from the phakic IOL again here, because you have to fold, these haptics are very big. So you have to fold the haptic one over the other, and then tuck them slowly below the iris. Usually in phakic IOL, we deliver the first leading haptics inside the, like below the iris, and then we go for the trailing haptics. But here I did it differently. As I said, this was my first experience, so I'm a bit slow in it. And again, once I finished the leading, then I went for the trailing haptics, and in the similar way folded the haptic one over the other. And finally the last one. It was not that difficult, but okay. It was the first one in my learning curve, and then a very, very thorough wash, because the intralenticular viscoelastics would not give me the desired results. So, and then asking the patient to look at the Purkinje lights, and I waited for a minute to ensure that the lenses were properly in position. Did a small PI, of course, peripheral iodectomy, because just to make sure, because I had 2 IOLs in the eye. And then seal the wound with hydro, procedure, and I looked good to me. The patient was looking as the patient was in topical, by the way, because I wanted to ensure that Purkinje images. The patient was in topical, extremely cooperative with me, I must say. And after a very thorough wash, and so this was the post-op. Very good AC depth, and her vision was 6/9 unaided. Nothing else that I could expect. It was just great. So we finished off the other eye as well, and there too she had very good vision, 6/9, and this is how she looks now. Thank you for patient hearing.
Anuja madam, any experience you have on this type of thing?
No, right now, as of now, they have not put in a piggyback, but like you said, depending on the case, that is why many times with very, very high refractive errors like this, many times you can get these refractive surprises.
So that's it. That's why
Only
they
thing is, you waited for almost a month.
Yeah, that was, I had to wait, ma'am, because these eyes are very long eyes. This lens I had never used, -17. So the ELP, I was very worried.
what is the question you just
So
listed?
Yeah.
another way of looking at it is, if we have done the refraction, say at 1 week. and
Yeah, we did
3
it.
days,
We did.
And if it is stable, then
No,
why
we
not
did
do
it.
an
First-
IOL exchange?
No, it was done. The refractive error did not change in 1 day, 2 day, 3 day, not like that. It changed over 1 week, 2 weeks, 3 weeks. See, 4.5 was my spherical equivalent maximum. But she was accepting something like 3, 2.5 because she was myopic. She was happy also.
The piggyback lens is going to depend on the post-operative manifest refraction
Yes.
anyways.
Yes.
So whether you did an IOL exchange or you put a piggyback.
I mean, it was not, I did not have the guts
there
to
was-
do a
there-
IOL exchange in that high myopic.
No,
And
but
in
as I
case-
know, there was change in refraction. First week and
Final.
final
Final. There was a change of
So
refraction.
she waited for stabilization of refraction.
Refraction, that's the
Now,
reason.
what is
And
there
I
in
did not
lit-
have the guts to change that IOL. 2 reasons. One,
No.
if I had broken the PC in any way, finished. Number 2 was that's -17.5 IOL was manufactured by a company.
That
So
also
now,
took time.
if that was correct or not, I never knew. Because I had no experience with that also. Because that -17 actually carried -17 or anything else. Because there's no other company available. And this was anyway COVID times.
So non-availability of the lens is the major problem.
No, the first thing they,
Monitor very closely now for the IOP and angles.
Yes, everything was done, ma'am.
AIOCMTC1
Total.
must be a very-
Everything was done because naturally, like a phakic IOL, I did everything. Workup was done in the way I did a phakic IOL.
no, the first thing is they don't say it as a piggyback IOL because it is not put in
It's
the
not
sulcus.
piggyback.
Yeah.
It is an add-on IOL.
Add-on IOL.
The second thing is, during calculation, biometry, the A scan used has to be different
Yes,
for plus lens
Yes.
and for minus.
yes.
So that has not been done in this case.
No, it has been done,
It
sir.
has been done.
Immersion has used 2 places
No,
we
no,
did.
A constant.
Okay, the SRKT and Barrett.
SRKT is all right.
No,
but
Barrett
the
was.
A constant varies from for plus IOL and minus IOL.
Okay, acha. Plus
It
IOL
is
and
there in the
minus.
literature. You have to use different A
A
constant.
constants.
Whether
not
that is
available.
used or not, we have to verify from the company.
Maybe. That's very difficult. Actually, I was. Yes, sir.
It is written about the fact, A constant.
We
Yeah,
do not
yeah,
know
it's
because that was
It's written,
customized.
sir.
She was highly myopic.
Yes, sir.
After operation, she was happy with plus 1.75. And then
Left eye, she was happy. Yes, she was happy, sir. Yes, she was.
then you targeted hematopia, 6.9 both eye on it.
No, I actually targeted I did not target emetropia. I targeted myopia in the initial stage. But I ended up into hypermetropia +4.
After during the
Second eye. Second eye, it was different, sir, because right eye I already got 6/9 after putting the add-on. So now my balance had to be.
can we take
So we'll go to the next.
6.91 and
Now next presenter.
0.75.
Dr. Anagar.
plus 2.5. Another eye. So that's
Present challenges white cataract.
and here these are plus 2.5 meter.
Yeah, it can be done. You can do a mixture. You can keep one eye hypermetropic.
Because it is not a great issue. Patient adapt the coagulation adapt to the intercepting lens जो होता है इसमें थोड़ा adaptation हो जाता है इसमें factor experience. So can we make it
Good point. point, good point. But what was in my mind was, since she was in the eye which was highly myopic, we could give her imetropia. So we talked with her and she said, can go ahead for the other eye. So it was with a mutual understanding. Yes, sir, it can be an alternative. Why not? We can give a space.
Yes, sir, that is a possibility.
Yeah, it's a possibility, definitely. Thank you so much. Thank you.
I'd like to thank the organizers for giving me an opportunity here. I would be speaking on challenges in white cataract. So basically what we do not want is the formation of the Argentinian flag sign, which is the major risk factor and the implications in such kind of intumescent cataract. So what happens is, the moment you puncture the anterior capsule, there is an egress of the liquefied cortex or a fluid, and because there is a high intralenticular pressure, it causes a radial tear in the capsular axis, causing a problem, and this on both the sides causes the Argentinian flag sign. So basically what we need to know is there are two types of white cataracts. The first type is where the actual liquefied cortex can be aspirated, it's fluid, and the second type is where you will not get fluid, but the cortical fibers themselves are swollen, and that is why there is a dry tap, and these are the cases which are more prone to a runaway, and you need to have a multifaceted approach to all this. Now here is the first case where we are showing a two-step rhexis. So you make a very small rhexis initially, like you can see here is just around 3 millimeters, and try to aspirate whatever kind of liquefied cortex is possible or milk it out. And now you make a nick with a micro scissors, with a micro forceps, you go in and then you have an extension. So you have now a very good adequately sized rhexis to go on with the next steps of the phacoemulsification. So routinely these are not very hard cataracts, and you can do a phaco chop and you can easily emulsify all these fragments very easily. So towards the end of the phacoemulsification, you need to be a little careful because there is no epinuclear shell and very little cortex, and even during irrigation and aspiration be very careful. So here we use the good red glow of the stereoaxial illumination, so that you can see how now the lens is extremely well centered in the bag. This is another case. Now you can see we are going ahead. We always use the side port so that the anterior chamber is well maintained. Here we are making a spiral rhexis instead of a two-step rhexis. So it depends on how much control you have on your hand. If you think it's going well controlled, you can continue with the spiral. Otherwise, it's best to make, what works best is make a small one and do a two-step. So here again the rest of the steps becomes easy. Most importantly, you need to have a very good anterior chamber stability and flatten the anterior capsule with viscoelastic, high molecular weight viscoelastic whenever you do a capsular rhexis in these cases. I usually do not prefer to do it through the main incision, otherwise you can open up the incision, the viscoelastic will come out, there is shallowing, and then that can cause more risk of the anterior capsular tear. So rest of the steps are the same. Now here you can see, in spite of all this, there are cases where you end up having an irregular rhexis. So the rhexis was trying to run out, so you try to pull it towards the center. Again here at this point you can see, because of some reason, you can see that it is not regular at all. So it's a very irregular kind of rhexis. So how do we now manage this? So you can make a nick with the for scissors. Even with the scissors, remember, do not make it completely, just a small nick, so that you can now use the microforceps on both the sides and try to salvage it. So the shape may not be circular, but at least what you need to have an adequate size so that it doesn't cause phimosis, and you are able to continue with the phacoemulsification well, and you should have a good centration of the intraocular lens. So this is basically salvaging the capsular rhexis. Now this was another case where we were trying to do a mature hard cataract, and like when it's a smaller one, you can also put in the lens and then go ahead and extend the capsular rhexis so that you have a good 360-degree overlap. This was another patient where the pupil was slightly on the smaller side. So it's better to have a slightly larger, adequately sized pupil, especially in these cases, because if it runs out and if you have a complication, it becomes very difficult to manage. So we are using iris retractors, and now you have an adequately sized pupil. So once we do this, aspirating the cortex from the center and try to maintain the rhexis edge
very close to and parallel to the pupillary edge. You can see even the mark of the trypan blue. But here, the last 1/4 is usually the most difficult, and you can see how now, at this point of time, it's gone out. So you can again use the micro scissors and complete it. But now you remember that there is an anterior capsular tear, so there should be no fluctuation in the anterior chamber. So whenever you are coming out of the eye, always it should be filled with viscoelastic. Be very careful while doing the chops. It should be gentle lateral chops away from the area of the anterior capsular tear, and very, very gently, so that there should be no turbulence in the, see again you're putting in the viscoelastic again and again. You can see the tear now where the iris retractor is there at one side. Irrigation and aspirate the cortex at that area in the last, and once you can do that, be very, very careful. Here again, see you're injecting viscoelastic before removing the irrigation. Always look for the flap motility sign. And now you're putting in the hydrophilic lens very, very gently, because if it opens out jerkily, it can again cause a tear to go in the posterior part. And the lens is put 90 degrees to the anterior capsular tear, and now it's time to remove the iris retractors. So finally we could salvage the case. Flax helps in such cases because it's a closed chamber procedure, and even if there is an egress of fluid, you can change the settings in such a way that you get a very good capsular access. Capsulotomy is more important. Here the nucleotomy is not so well done with the flax, and always remember these are postage stamp perforations. So you can actually extend the capsulotomy once you have the basic flax capsulotomy done, and the rest of the procedure is as usual, the phaco chops and the rest of the procedure. Zepto also is a very good technology that you can use in these patients to get a perfect, well-centered capsular axis, and very well-centered. So here we are using a multifocal intraocular lens also with the Zepto technology, and you can see it's a very well-centered intraocular lens. So in order to optimize outcomes in all these patients, it's important to stain the capsule well, use high viscosity viscoelastic to flatten the anterior capsule. Needle or microforceps is especially very, very important. Use the side port instead of the main incision. Always maintain a closed chamber. See that there is no shallowing of the chamber which can cause the anterior capsular tear. Supracapsular phaco, this is probably only the one condition where if you have if you have an anterior capsular tear, for example, then this could be possible, and keep the parameters low towards the end. Thank you so much for your kind attention. Thank you.
Excellent presentation.
Thank you.
Next is Dr. Rishi Raj Singh.
To AIOCMTC Scientific Committee for giving me this opportunity. My topic is choice of presbyopic IOL. As we all know, increase in the life expectancy and change in lifestyle, increasing number of patients now demanding for the independence for the near and intermediate vision for their daily activities. There are a lot of treatment options available for the presbyopic IOL. But the patient satisfaction depends on the careful and individualized selection based on the pre-existing conditions, visual need, realistic expectation, knowledge of the different optical design, visual performance of the IOL, proper surgical technique, and eventual complication management. The critical success factor for these IOL is the patient counseling, precise biometry, and the proper surgery. Suitable candidates are keenly interested in spectacle independence, easygoing personality, willing to understand limitation, indoor work, and highly dependency on the intermediate vision. But we should avoid this type of lenses in type A personality, night drivers, in the decentered pupil, traumatic subluxated cataract, in surgically complicated cases. For the implantation of the premium IOL, preoperative workup is very important, especially the IOL power calculation, abrometry, angle alpha measurement, and a dry eye workup. A good optical myometry, and if it is not available, a good immersion A scan is very important for the premium IOL implantation. Then measurement of the angle alpha, because if the multifocal premium IOL decenter, patient sees through the diffractive ring and not through the optical center, it increases the chances of blur or double vision. Measurement of angle alpha is more important than the angle kappa. And there is a wide range of IOL available in the market. So a careful and complete examination of the patient and IOL selection, which is based on his lifestyle and visual need, will be recommended. Because in today's world, vision at each distance is equally important. Now most of the work is doing on the near, because most of the patients are working on the laptop, computer, so the intermediate vision is also very important, as well as the near vision nowadays. So informed decision making prior to the premium IOL implantation is very important. Based upon the different physical properties of the IOL, presbyopic correcting IOL can be divided broadly into three types, either EDOF, multifocal or trifocal type of IOL on their physical properties. The multifocal IOL basically are two types, refractive or diffractive, based upon the physical mechanism used by the lens to cause the bundling of the IOL. Multifocal IOL either refractive or diffractive, and among these the refractive type of IOL is the pupillary dependent, very sensitive to their centration. It may causes the glare and halos and reduces the contrast sensitivity as compared to diffractive type of IOL, which is pupillary independent and more tolerant to their centration as compared to refractive type of IOL. In both type of lenses, diffractive and diffractive provides good near vision as compared to refractive type of IOL. So multifocal IOL provides good near and distant vision in all the light conditions. But nowadays there is an emerging technology which is the EDOF type of IOL, extended depth of focus IOL, which provides good intermediate distant vision as compared to the multifocal IOL. The basic principle of the EDOF IOL is to create a single elongated focal point as compared to monofocal, which provides only a focus only one single point, and multifocal IOL, which has either two or in trifocal three discrete points. So EDOF IOL provides a continuous range of focus without a clearly asymmetric IOL power distribution. This decreases the photopic phenomena. EDOF IOL can be achieved either with increasing the spherical aberration or by employing the pinhole effect. So as compared to multifocal IOL, EDOF IOL provides a good intermediate vision without the halos and glare. So the treatment options that are available for the presbyopic correction, either multifocal, EDOF or trifocal, all the three lenses provide good distant vision, but the intermediate vision is very good with the EDOF IOL or trifocal. But in the EDOF and trifocal, the glare and halos are very minimum or nil in the EDOF type of IOL. So in conclusion, to obtain a success after surgery in these type of patients, selection of the patient, preoperative evaluation of the ocular surface, correct IOL selection, good surgical techniques for this, for the good surgical outcome, spend some chair time with the patient to explain all the factors involved in the outcome of the surgery and possible complication management. Because even the premium IOL implantation, sometimes patient may be dissatisfied. The most common complaint may be blurring of the vision, photopic phenomena, maybe due to the residual refractive error, PCO, dry eye, inadequate pupillary size, wavefront abnormality, and IOL decentration. So these complications can be managed properly and may affect the visual outcome, and it all leads to the good patient satisfaction and quality of life. Thank you.
So which type of, thank you very much for this presentation, but just a question, which type of EDOF IOL is available in India?
Sir, EDOF IOL, like in Appasamy, they are providing super...
No. I don't want the name of the company. Basing on the mechanism...
Pinhole effect.
Pinhole effect, there has to be a hole in the center of the lens. So which type of available, whether spherical aberration based EDOF are available or pinhole based available?
Mainly in the pinhole.
The topic I am going to cover is unravel basics to the patient, and you are ready to be congratulated, but instead when your patient starts screaming, "Doc, I hate these unwanted images that you have given me," this is not what you wanted to hear. So what is dysphotopsia? Dysphotopsia are undesired optical images associated with otherwise uncomplicated, uneventful cataract surgery. Patients are incredibly unhappy and they move from one ophthalmologist chamber to another, and when they are told that your surgery is perfect, why? Because photopsias are visual perception that arise in the absence of light stimuli, but the visual disturbance of dysphotopsia do not occur in the absence of light stimuli. In the literature, terms such as photopsia, entoptic, and photic phenomena have been used, and the term dysphotopsia was used for the first time in June 2000 by James Tester. and both surgeons and patients are unhappy, and when the surgeons tell the patient that it will go away in time, it does not always turn out to be true in 100% of the cases. Some of these patients are so upset that they have filed lawsuits against ophthalmologists and lens manufacturers. So two major categories. I'm going to cover only the part arising from the IOL edges. Edge reflections are called positive dysphotopsia and edge scotomas are called negative dysphotopsia. We wanted some desirable traits in foldable lenses that have led to undesirable optical phenomena. We wanted thin lenses to go through small incision, it acts like a mirror. We wanted square edges to decrease PCO, it causes internal reflections. We want hydrophobic IOLs because they cause less PCO, but because of low anterior curvature and high refractive index, they cause these optical phenomena. Truncation, bitruncation, all leads to mirror-like effect. So negative dysphotopsia was reported for the first time in 2000, and it is the commonest type. It is less understood, more debilitating, and it unfortunately occurs only with perfect surgeon, perfect surgery, good IOLs, and it is a sickle-shaped dark shadow or a crescent that gives the impression of a shade over the temporal peripheral region of the patient vision and has been likened to horse blinders. So why does it occur? Imagine temporal light of rays. When they strike the nasal edge of the IOL, it is reflected back. The simplest theory is that now there is no light rays to be refracted, so there is a edge scotoma. But when ray analysis was done by by Holliday, what he found was that there are three types of shadows: type 1, type 2 and type 3 shadow. Imagine from the sharp edge, light rays are reflected from the posterior surface of the IOL and the edge of the inferior edge of the IOL. So there is scotoma between this maximally refracted rays from the posterior edge and from the inferior edge, and so there is 2.5 to 3 degrees of this shadow which is not illuminated by the light rays, which causes negative dysphotopsia. So in literature, three types of causes have been listed. First is light entering eye from the temporal periphery is reflected and there is no light rays to be refracted. And some simplistic explanation given is it is just like ring scotoma in the phakic glasses of the yesteryears. So it is manifested by a dark shadow in the temporal periphery. So what are the optical factors required for negative dysphotopsia? There are primary and secondary factors. Primary is if you have a small pupil, there is more distance behind the pupil, and it has been calculated. The crystalline lens is 4 millimeter, whereas if the pseudophakic lens is less than 1 millimeter. So after removing the cataract and implanting a IOL, there is more distance between the iris and the IOL, and it has been calculated that if it is 0.06 to 1.2 for acrylic and 0.06 to 0.62 for silicone, this predisposes to development of dysphotopsia. Sharp edge design of the IOLs, functional nasal retina that extends anterior to the shadow, and the secondary factors are high refractive index of optic material which is there in hydrophobic lenses, large angle alpha, nasal location of the pupil, transparent status of the peripheral nasal capsule, and more with high plus lenses. Why this dark shadow occurs only temporally and not nasally? Because light coming in nasally is tempered by the nose, eyebrow and cheek, and second factor is that the nasal retina may extend further anteriorly than the temporal retina. So these are some of the pictures which have been drawn by the patients, and these are the temporal dark shadows which haunt them. What is the incidence? It is said that in the immediate post-operative period it is 20%, but it decreases in the long term to about 5% by 6 months, and less than 2%, 2.4% after 2 years. So the dysphotopsias can be transient. Why it occurs is it resolves in 2 weeks, and it is due to the hydration of the temporal clear corneal incision. Temporary is the one which really resolves within 6 to 12 months. I told you incidence decreases from 20% to 5%, and why it disappears is because as the peripheral nasal rim of the anterior capsule opacifies or when there is neuroadaptation. But it is the persistent variety consisting of lingering cases that annoys the patient and perplexes the surgeon. So I told you it occurs with well-centered in the back PC IOLs. It does not happen with poorly centered IOLs. I'll just take a minute, sir. It does not happen with sulcus IOLs, does not happen with AC IOLs, occurs with hydrophobic IOLs, does not occur with hydrophilic IOLs, does not occur with silicone IOLs. Increases with bright light, dilate the pupil, problem resolves. Constrict the pupil, problem worsens. Since no medical therapy seems to work, surgical management may be required in some subgroup of the patients. So on what is the surgical management? Either we can remove nasal annulus of the anterior capsule or place shoulders of the haptics of 3-piece IOL horizontally, do reverse optic capture, piggyback IOL, or there are some newer IOLs like anti-dysphotopic IOL by Mascot or Mary Tessignon. What you can do is take the patient on the slit lamp and just give yak shot to the peripheral annulus of the nasal anterior capsule, and this goes on to prove that some of these patients may be having this dysphotopsia because of the shadow of the anterior capsule nasally. So by removing that annulus, that problem resolves. By placing single piece IOL horizontally, why it resolves is because this haptic acts as the extension of the optic. So light rays may bleed through this optic haptic junction and that shadow may be illuminated. Reverse optic capture, what you do is you bring out the IOL edge in front of the anterior capsule. First you bring out the nasal edge of the IOL optic from in front of the anterior capsule, then temporal. So what it does is, again the shadow factor of the anterior capsule rim is taken care of. Piggyback IOL, how does it help is, by placing one more IOL, it decreases the distance between the iris and the IOL, and it also covers the anterior capsule. This is a newer IOL which has been made by Mascot. What it does is, it has a ridge on the optic edges into which rests the rim of the anterior capsule. So this part is, that's why it is called Mascot anti-dysphotopic IOL. Bag in the lens IOL is that instead of placing IOL in the bag is taking care of the IOL. So this IOL is supported by anterior and posterior capsule, for which we need to do both anterior and posterior capsular access, with which many of our surgeons are not very comfortable. IOL exchange is the last resort. When the problems do not resolve in 6 months, then consider IOL exchange. And what newer IOL you have to put now is, replace it with a IOL which has low refractive index, not acrylic, rounded edges, optic diameter of the lens has to be large, surface reflectivity low, and move more power to the anterior surface and less to the posterior surface. But imagine if you have already implanted this lens and patient has developed negative dysphotopsia, then what do? So precise reason why only certain patients and not 100% of the patient develop negative dysphotopsia still remains a mystery. Reverse optic capture and piggyback IOL implantation in the sulcus are the most successful approaches for negative dysphotopsia. So surgeons need to know that dysphotopsia is a real legitimate problem. Don't fool the patient by saying all is well. Yes, you can counsel that in the near future all will be well. Thank you everyone for your kind and patient hearing. So if we are able to remove these haunting images from the field of vision of these distressed souls, smile will return back to their countenance. Thank you everyone for your patient hearing. And I will also take this opportunity for your support for the candidature for member scientific committee in the coming AIO selection. Thank you, sir.
Thank you very much, sir. This is really a distressing problem for the patient and for the surgeon also. Exactly. Because they bother so much because of their problem.
Only counseling is the only answer?
No, my...
No, sir. I covered the medical part and the surgical part.
No, that is correct, but my point is, as you rightly said, during surgery we have to put the uptake horizontally.
If single piece IOL is there,
Single piece.
place it horizontally, but if the problem occurs, either you can yak the nasal rim of the anterior annulus of the anterior capsule, and secondly what you can do is that the third important option is, there was video also shown by Dr. Ram yesterday, do the reverse optic capture. Take the patient.
No, that is the surgical thing.
Surgical management.
So
You
no
just
one-
piece of the nasal edge of the optic in front